Respected dignitaries and my friends, good evening to all. I would like to thank my senior consultants and organizing team for giving this opportunity. I am going to present a case about how we dealt with a severe calcified coronary artery lesion. Case history: this is a 68 years male with no known risk factors, had a triple vessel disease, normal LV ejection fraction, and had underwent a bypass surgery with 3 grafts in 2003 with Lima to LAD, SVG to OM2 and SVG to PDA. So now he presented with effort angina class 2 with normal LV ejection fraction. Since he had a class 2 angina, we did a treadmill test which was stage 2 positive. And to quantify the reversibility of ischemia, we did a stress MPI scan which showed a moderate reversible ischemia in RCA territory. Coronary angiogram showed a native left main with calcified triple vessel disease, functioning Lima to LAD, occluded venous grafts. So CCG showed a normal sinus rhythm with ST depressions in chest leads. Echocardiogram was normal. This coronary angiogram showed a short left main with LAD occluded ostium, and his RAO caudal view showed a significant disease in proximal circumflex and significant disease in major OM proximal part, and there is a significant calcium in the left system also. Coming to the RCA injection, there is significant calcium seen angiographically. A little abnormal course of RCA with tight stenosis in proximal RCA and mid RCA. There is a lesion in the osteoproximal PDA as well, which is a small vessel. Lima to LAD is functioning and venous grafts were occluded. So in view of the stress MPA showing a moderate reversible ischemia in RCA territory, we went with a plan of PTCA to RCA. We took a check shot with a 6 French multipurpose guiding catheter which gave an excellent support. And as there is severe calcification seen angiographically, we post-dilated with a 2 8 mm NC balloon, and then we went with rotablation with a 1.5 mm rotalink burr. There was a significant drop of about 4,000 to 6,000 rounds per minute. So after rotablation, we pre-dilated with a 2.5 12 NC balloon, and then we did imaging. Pre-PCI OCT was done. So this OCT run started from the distal RCA and showed a significant calcium in almost entire mid RCA as well as in proximal RCA. So there was a protruding nodule in the proximal RCA as well at this point. This is another run from mid RCA to ostial RCA. So there was almost a 270-degree calcium with a length of more than 7 mm, thickness of about more than 0.5 mm. So this analysis showed a lumen gain of about 2.33 millimeter square in this segment of the RCA and about 2.15 mm square in the proximal segment of RCA. So we can see in all the cross-sectional images there were a significant calcium burden in the entire RCA. Here, and there is a protruding nodule here at 0.7. So pre-PCI OCT findings, the ROTA created a lumen gain of proximal RCA 2.15 mm square and mid lesion 2.35 mm square. And coming to the calcium score, it is a thickness more than 0.7 and length of 9 mm and arc of more than 180 degree. So calcium score of 4. So we decided to do an intravascular lithotripsy with a 312 mm balloon, 60 pulses were delivered. So this is the intravascular lithotripsy video clip. So finally, we stented with the 3.5 48 mm from distal to mid RCA, and from with 3.5 33 mm from mid to proximal RCA overlapping, and post dilated with a 3.5 into 15 mm NC balloon, and post stenting OCT was run. This showed no edge dissections, adequate expansion of optimal expansion, but there was a malopposition of about 3 mm noted in the proximal RCA just before the overlapping segment. So there was optimal expansion, and in this mid area proximal to the overlapping segment, there is a malopposition. A significant malopposition was noted. So we optimized the PCI with the further post dilatation with a 4 into 6 mm non-compliant balloon, and this is the final check shot. So coming to the decision algorithm for treatment of calcified coronary lesions, when there is mild calcification, debulking strategies are not needed. When there is moderate or severe calcification and the lesion is uncrossable with balloon, we can go with the rotational atherectomy or orbital atherectomy, and then we can proceed further. And if there is, if we can cross the catheters for imaging, we can assess the calcium score. If the score is either 3, 4 or 5, we can go with lithotripsy and then proceed with the case. In the case of IVS assessment for calcium length more than 5 mm and calcium arc more than 270 degree, add an extra point to the score, that comes a score of 5. So coming to the take-home message, severe calcified coronary artery lesions are an Achilles heel for every interventional cardiologist. Stent underexpansion is an important phenomenon associated with these lesions, which leads on to adverse events. So meticulous planning and intravascular imaging are very important. Proper plaque modification techniques prior to stenting will help in success of the procedure.